Hi, my name is Connie Koklanis and you're watching the video Detection of Strabismus Cover Test. The cover test is the single most important test that we as orthoptists can utilise in detecting strabismus. So far we've learnt about observation and corneal reflection and utilising those to detect strabismus. However, what we were talking about there is detecting a manifest strabismus. So a decentered corneal reflex is indicating that there is a manifest strabismus, but it gives us no information about a latent deviation. Also, upon observation, if the eyes are aligned, we don't know if there is an underlying latent deviation. The only test that can do that is the cover test. That can give us information about both, whether a manifest deviation is present and also whether a latent deviation is present. Not only that, it can also give us information about the control of a deviation. If a patient is an intermittent deviation or a latent deviation, we can have a look at the control of a deviation through the cover test. Also, where we have a manifest strabismus and we're looking at the way in which the patient takes up fixation or holds fixation during that cover test procedure, it's giving us information about where they prefer to use one eye over the other and thereby potentially information about visual acuity. So the cover test is far more comprehensive than observing a patient simply or having a look at a patient's corneal reflection. You need to use the definitive test of detecting strabismus, which is the cover test, which then confirms your observation and confirms what you saw on corneal reflection. Now, when we perform the cover test, we do so at a variety of distances. And standardly, we'll do this at near, at 1/3 of a metre, and at distance at 6 metres. Now, why do we do the cover test at those two distances? Because we want to alter the patient's accommodation. At 1/3 of a metre, we're asking the patient to do 3 diopters of accommodation, assuming that they're metropic. And at 6 metres, the patient's doing a negligible amount of accommodation. So we're trying to compare the patient at near when they're doing a greater amount of accommodation versus the distance where they've relaxed their accommodation. And the reason we do this is because strabismus can be classified into accommodative and non-accommodative, and we need to know whether there is a change in this deviation based on accommodation. So at near when they're accommodating more versus at distance when they're accommodating less. In some instances, we also go to perform the cover test at greater than 6 metres. Now, this is usually performed when you ask a patient to look through a window, so they start to look out into a far distance. And we do this specifically in exo deviations, and we'll come back to that a little bit later in this course. Now, when we're performing the cover test, we're asking the patient to look at a target and to fix on a target. We have 2 options here. We have the option of asking the patient to look at an accommodative target or a non-accommodative target. The standard is that you have the patient fix on an accommodative target because this controls your patient's accommodation during testing. What we mean by an accommodative target is one such as this, where there is detail and you're asking the patient to identify something. So here we've got letters, and so you would ask the patient to look at the smallest letter that they can and to read those out. What you're doing there is you're forcing the patient to exert their accommodation in order to see the target clearly. So if I'm performing the test at near at 1/3 of a metre, in order for the patient to see the N5 font clearly, they need to exert that 3 diopters of accommodation. So what I'm trying to do there is ensure that my patient is accommodating when looking at that target. If, however, I use a torch, such as this, and ask the patient to look at it, I'm not ensuring that they're exerting accommodation because they don't need to see the detail of a torch. When you ask a patient to look towards a torch, there's a ray of light coming from that torch. They can relax their accommodation if they want and fix on that target because you're not asking them about any level of detail. So with an accommodative target, you're controlling accommodation and you're trying to push them to exert as much accommodation as possible. Versus a non-accommodative target, you're actually relaxing the patient's accommodation and you are risking uncontrolled accommodation because they might be trying to clear it at some points, not trying to clear it at other points and so forth. Now, when you have younger children, say for instance the age of 2, they don't know their letters, and it's not possible to ask them to look at an N5 font and identify the letters. So in these instances, we use toys or pictures, and when you do that, you need to also try and force the patient to identify elements of the pictures that you have there to try and force that accommodation. Finally, we perform the test both with glasses and without glasses if the patient has a refractive correction. Now, the reason we do this is because we want to see whether, by correcting the refractive error, whether there is an influence on the strabismus. Now, by correcting the refractive error, we can have an impact on accommodation. As an example, if you have a hypermetropic individual, by giving them plus lenses, you allow them to relax that accommodation that they needed to exert to see clearly when they were uncorrected. Okay, and so what we're wanting to see there is, if we correct that hypermetropia, does it influence the strabismus? And just before we move on to the components of the cover test, I just want to bring your attention to the occluders. There's two options. You can use a black occluder where you can't see under the cover, so you can't see the eye under the cover when you're cover testing, or you can use a Spielman occluder, which is a translucent occluder, such as this, where you can see under the cover and you can see the eye, but the patient can't see through that occluder. They've only got diffuse light, no contour, so it's still a very good occluder to use in cover testing. Now, you're aware that the cover test actually has three components: the cover, uncover, and alternate component. The cover component of the cover test is detecting manifest strabismus, the uncover is looking for latent, and the alternate is a fully dissociative test that won't distinguish whether you have a latent or manifest strabismus. Okay, let's have a look at each of these components using the simulator over here. So, in this patient, we observe that the patient looks relatively straight, and what we want to now see is, does this patient have a manifest strabismus? So, I would cover the right eye in the first instance, and when I go to cover, I want to look at the eye that's uncovered, so the left eye. So, I'm covering the right, and I'm only interested in what is happening to that left eye. And what I saw was no movement of that eye when I covered the right eye. Let's do that again. No movement of the left eye, no movement of the left eye, no movement of the left eye. That confirms to me there's no left manifest strabismus. And this is the cover component. We have to repeat that on the other side. Let's have a look at the right eye now. So cover, there's no movement of the right eye. So I have confirmation that there is no manifest strabismus of the right or the left eye. So in this instance, we now move to look at the uncover component. Now we're going to look at what's happening under the cover. So I'll occlude the eye, and what I'll look now at is what happens to the eye when I take the occluder away. So taking the occluder away, there was no movement of the right eye. Let's do that again, no movement of the right eye. So I've got confirmation there that I'm not observing any latent deviation. And again, I'll do that with this eye, and there's no latent deviation there. With a Spielman occluder, you'll be able to see under the occluder, in which case you can actually observe what's happening when the occluder goes on rather than when it comes off. Okay, I'm just going to go back to the black occluder. And let's now try the alternate cover test. So what we want to do here now is fully dissociate the eyes, which means I cannot allow the patient to be binocular at any point in time. So have both eyes open and looking at the target. So I will cover one eye and immediately move to the other eye. And this is the alternate. And what I'm looking at is the eye as I uncover it. So looking at the right eye, left eye, right eye, left eye, right eye. And I'm seeing no movement. So I have confirmation here now that this patient does not have a manifest strabismus, so they're orthotropic, and they don't have a latent deviation, so they're orthophoric. Let's take a look now at a patient who has a manifest strabismus. Okay, here we can see upon observation that the right eye appears to be inward turning, so there seems to be a right esotropia. And if we could have corneal reflections, we expect that we would see a temporal corneal reflection somewhere here. Okay, so the first component will be to cover the eye, and I will cover the left eye because what I want to see is, will that right eye take up fixation and will I have confirmation that this is an esotropia or right esotropia? And there we go. We see the eye move out to take up fixation. Okay, let's try that again. There it goes, out to take up fixation. So the eye is moving in the opposite direction to which the deviation lies. So this is an esotropia, and the eye will move outwards to take up fixation. There are some instances where the patient may not take up fixation. So if the visual acuity is very poor in that eye and they can't see the target, it may be difficult for them to take up fixation. Other reasons might be eccentric fixation, or if there is a mechanical restriction where the eye is unable, for instance, to take up fixation. So there are some instances where observation and corneal reflection will indicate that there is a right esotropia, but cover test is unable to confirm that there is a manifest strabismus present. The other thing we're observing during the cover component of the cover test is when that patient takes up fixation, does it hold fixation once I take the cover away? So I'll observe that right eye, and when I let it go, we see that it goes back to being an ESO deviation. So let's have a look again. It just returns back. This tells me that it's not holding fixation. The patient prefers to fix with the left eye. And this also tells me that it's likely that the left visual acuity may be better than the right visual acuity because they prefer to use one eye over the other. Patient who has no preference for using the right or the left eye has an alternating strabismus. Let's have a look at what that would look like. So if we just have a look at that there, if I cover now, when I take the cover away, the patient will hold fixation and will now have a left esotropia. So in this particular instance, I would then cover this eye and we have confirmation of the left ESO. Let's take it away. That's holding fixation. We're covering this eye, that's holding fixation. So there is no fixation preference, and this usually occurs when the vision is relatively equal. Okay, I'm going to go back to that right esotropia. If we move on to perform the uncover component, what will we find? So let me cover this eye, and when we're looking at the uncover component, what we're now interested in seeing is what happens under the cover. So let's have a look. Okay, what do we see there? We see that the eye is moving out to take up fixation. Does that mean we have an esophoria? No, it does not mean we have an esophoria. The movement we see there is purely because, as we'll see the right eye go back to being an ESO, the left eye returns to taking up fixation. So the only reason we've seen movement under cover here is because of the laws of innervation, and we're seeing the eyes moving together as the right eye returns back into position. Let's use the Spielman occluder to clarify this. When I cover the left eye, what happens is that the right eye will take up fixation because I've blocked the vision of the left eye. And so the left eye under the cover has become esotropic because of the laws of innervation. The right eye is not going to move on its own. Eyes move together. So as the right eye takes up fixation, the left eye becomes esotropic. So when I take the occluder away, all I see is the left eye returning to take up fixation. I'm not seeing a latent deviation. And this makes logical sense. Patients with a large manifest deviation do not have underlying latent deviations also. Let's now move to the alternate component of the cover test. So if I cover that eye, I'll see it turning out. It's turning out. So I know I have an ESO deviation here. It's very clear that I've got an ESO. Both eyes are moving outwards. But if I did the alternate cover test on its own, I couldn't tell you whether that was a latent deviation, whether it was a manifest deviation, or whether it's a combination of both, because the alternate cover test cannot distinguish between the two. So what does a latent deviation look like? well, let's have a look here where we appear to have a patient who has straight eyes. Let's say corner reflections are symmetrical, and the cover component of the cover test detected no manifest deviation. So what we're now interested in is looking under the cover, and so let's try with that right eye. I've covered that right eye, and now what I'm interested in is looking under the cover and what movement do I see. And now I see this eye return from an inward position out. So it's an ESO deviation. Take another look at that. And it's an esophoria. And we can see that this time that eye movement is not occurring because of a conjugate movement made because there was a manifest strabismus present, but simply because I've dissociated the patient. So by covering the eye has assumed an ESO position, but it returns back to being straight. So the dissociation is what led to that eye turning in, not the fact that there was a manifest strabismus and the eye moved in conjunction with the other eye. One more point to make about latent deviations. When you detect a heterophoria, you need to document in your notes the recovery. So for the manifest deviation, we've recorded whether the patient can take up fixation or hold fixation, not hold fixation. For the latent deviation, we need to talk about recovery. And what we're talking about here is how quickly after we remove the cover does the eye return to its original position? Does the patient regain binocular functions or binocular single vision? So let's come back to this patient. Let's pop the occluder on. And here, under the cover, the eye has gone into an ESO position. So what I'm now interested in is when I take the cover off, how quickly will it return to its original position? Okay, so I'm looking at the speed at which recovery occurs. And recovery can be rapid, so very quickly, to slow recovery. And the slower the recovery, the poorer the control of the deviation. So here recovery is giving us some information around control of the latent deviation. So an esophoria with rapid recovery is telling you that yes, the patient has a latent deviation, but they have good control of that latent deviation. In a patient with an esophoria with slow recovery, it's telling us that there's a latent deviation, the patient is struggling or having some difficulty around maintaining binocular single vision or controlling that deviation. And we're really interested in that, particularly when patients come to clinic with symptoms, asthenopic symptoms, and we detect that there is a latent deviation with slow recovery or issues around recovery, because that's telling you you've got an issue here with control that may be leading to symptoms. And finally, I want to make a point around vertical deviations. Here we now have a patient with a hyperdeviation, a right hypertropia, and we would expect that the corner reflection would be inferiorly here. When I cover the left eye, the eye will come down to take a fixation. It's moving in the opposite direction to the deviation. So the deviation was up, the eye moved down. But look at what happens to the left eye. There is a left hypotropia. So with vertical deviations, due to laws of innervation, when an eye is up, when that eye takes up fixation, the other eye will be down. So we actually go from a hypertropia to a hypotropia as the eyes alternate. In horizontal deviations, in the ESO and exo deviations, the strabismus always remains in the same direction in the sense that it'll go from a right esotropia to a left esotropia. But in a vertical deviation, we'll go from a right hyper to a left hypo. What I do want to point out is that even though the vertical deviation is altering from a hyper to a hypo on alternation, the eye that's higher or lower is always consistent. What do I mean by this? Well, in this particular image, what we see here is that the right eye is higher than the left eye. So we've got a left hypotropia, and we can also call this a right on left. Okay, so the right eye is higher than the left eye. When I cover this eye and the left eye takes up fixation, I have a right hypertropia, but I still have a right on left. the right eye remains being higher than the left eye. So that's what remains consistent in vertical deviations. So how do we go about recording the results of a cover test? Let's say this is our patient and they've got a constant right exotropia and it looks exactly the same near and far. We would indicate CT for cover test, indicate whether the test was done with or without glasses, so without glasses here, without correction, and the results for each distance that we performed the test. And so here we have at far, it was a large right exotropia, it did not hold fixation, NHF, not holding fixation, and at near we have exactly the same result. These two results here are exactly the same finding, just written slightly differently. Here we've dropped the near and far, and the apostrophe equates to, this is a result for near, and this is the result for far. Here, because there's no difference between near and far, you can also just put it in a single line where you've got large RXT, so in the distance it's an RXT, and at near it's an XT, and it's assumed it's an R if it's not put there. And not holding fixation is for both those distances, given that it's been put at the end there. So there are slight variations that you'll see in the way in which a clinician records the results, but it's important that you can interpret each of those findings. So how do we go about recording intermittent deviations? So where a patient has sometimes a manifest deviation and then sometimes controls their deviation. Let's say this is our patient and in the distance they look like this all the time, where they appear to have a manifest right XT constantly. But at near, they flip between having a right XT and being aligned. So they're intermittently, XT intermittently controlled. So again, we would say CT for cover test without correction, far, large RXT holding fixation. So in this instance, we're indicating here that it's constant, but at near, we add brackets to the T to indicate that it is intermittently manifest. So sometimes this patient is controlled, sometimes the XT is noted. Now you can also add underlines to indicate whether it's mostly manifest or mostly controlled as detected on the cover test. So here if you underline the T, it means that it's mostly manifest, but if you underline the X, you're indicating that it's mostly latent. Again, these two results here are exactly the same as that first one there. So how do we record a latent deviation? Let's take this scenario where now we have a patient who has no manifest deviation near or far, but on cover test we've detected an exophoria and the recovery was very quick and rapid. How do we record that? Well, here we've got cover test without correction. We've documented that it's a small in size. We have an exophoria in the distance, an exophoria at near, and rapid recovery at both those distances. So we see now that we're talking about recovery for the latent deviation whilst we're talking about holding or not holding fixation for the manifest deviations. One more thing to point out, I haven't documented which eye was deviating, and that's because generally latent deviations are not monocular, and when we would have covered the eye, say the right eye here, we would have seen an exodrift under the cover. And when we covered the left eye, we would have seen an exodrift of the left eye. So overall, dissociation using a cover elicits this patient's latent deviation, which is an exophoria. So whenever the patient is dissociated, whether you put the cover over the left or the right, the patient has a natural drift outwards. Okay, that brings us to the conclusion of this video. Thank you for watching.